Hello everyone, so I'm going to continue with the series of the week before the exam, just a quick answers of the important questions or the high yield questions. So we're going to start with the trunk and thorax as well. And as you can see, I divided the trunk and thorax into abdominal muscles, abdominal vessels, abdominal organs, and then you have the abdominal region and transverse section in the abdomen, and then thorax, and then the more clinically or applied anatomy in this area. So I'm going to start with abdominal muscles and I'll be asked a few questions and I will start answering them exam-like, and I would advise you do the same and then compare your answer with my answer and also the answer that is on the screen. So starting by abdominal wall muscles, first question is asking external oblique, origin, insertion, nerve supply, and direction of fibers. So the origin of external oblique, it arises from the lower 8 reps bilaterally, and the insertion, the fibers will be directed downward, forward, and medially, will be inserted in the xiphoid process, the linea alba in the midline, and also the pubis downward, and will end by forming, and also the iliac crest downward as well, through the fleshy part and the aponeurotic part. And it will end by forming the inguinal ligament in the lower end. So that's the origin and insertion, and it's supplied by the lower 6 thoracic nerves. So I think I said everything. So let's say the origin starts from lower 8 reps, yes, and the insertion, the xiphoid process, linea alba, pubic tubercle, and the anterior half outer border of iliac crest. I know I just said iliac crest, ideally I should say anterior half outer border of iliac crest, and I also mentioned the formation of the inguinal ligament by backward deviation of the fibers. The nerve supply would be the lower 6 thoracic nerves from T7 to T12, direction of fibers downward, forward, and medial. Okay. What about the internal oblique? Origin, insertion, nerve supply, and direction of fibers. So the internal oblique origin, it arises from the thoracolumbar fascia, the iliac crest, and also the pubic tubercle. The insertion will be inserted in the pubis and also in the linea alba and the xiphoid process and the lower 3 reps as well. Direction of fibers is upward, forward, and medial, and the nerve supply is the ilioinguinal nerve, the iliohypogastric nerve, and the subcostal nerve, and some of the intercostal nerves as well. I don't remember which costal nerve, but maybe the lower 6 intercostal nerves. I'm sorry, I mentioned earlier that it arises from the pubic tubercle. It actually gives an insertion to this area, but not an origin. Let's see the answer. So origin, like I said, thoracolumbar fascia, iliac crest, and inguinal ligament. I did not mention inguinal ligament. Insertion will go to the pubis via the conjoint tendon and linea alba and the inferior border of the lower 3 reps. Okay, that's the insertion. I said pubic tubercle. Ideally, it should be pubis via conjoint tendon, but it's basically the same at the end. The nerve supply will be the iliohypogastric, the ilioinguinal nerve, and lower 6th. I was confused about this, but it's lower 6th thoracic nerves as well, and also the subcostal nerve. Direction of fibers, upward, forward, and medially. Next question is asking about the diaphragm. What are the openings of the diaphragm? So in the diaphragm we have 3 openings. This include the vena cava opening at T8 and the esophageal opening at T10 and also the aortic opening at T12. The vena cava opening contains the inferior vena cava and also the phrenic nerve. And the esophageal opening contains the esophagus and also the esophageal branches of the gastric vessels and the vagus nerve as well. And ending by the aortic opening, which is at the level of T12, it contains the aorta and also the thoracic duct and the azygos vein. If we check that, yes, inferior vena cava, phrenic nerve, esophagus and vagus nerve, and sometimes right across of the diaphragm, aorta, azygos, and also thoracic duct. What are the attachments of the diaphragm? The diaphragm is an involuntary muscle and it has a central origin, a central insertion into the aponeurotic central tendon of the diaphragm, and it also has insertion all the way around into the outlet of the thoracic cavity. And that will arise from the front, from the back of the xiphoid process, from the inner surface of the lower 6 costal cartilages, and will also, on the vertebral origin, it will arise from the right and left cross of the diaphragm. The right cross of the diaphragm arises from the anterior surface of the upper 3 lumbar vertebra, and the left cross of the diaphragm arises from the anterior surface of the upper 2 lumbar vertebra. And then we have the median arcuate ligament, the medial arcuate ligament, and finally the lateral arcuate ligament. The median arcuate ligament arises between the 2 crura of the diaphragm, and the medial arcuate ligament arises from the crura of the diaphragm or the body of the vertebra to the transverse process. And finally, the lateral arcuate ligament arises from the transverse process to the costal cartilage. All right, so that's the origin and insertion of the diaphragm. You see the origin, that will be sternal, xiphoid process, costal, lower 6 costal cartilages, vertebral, like we said, crura of the diaphragm, and finally median arcuate ligament between the 2 crus, medial with an L on the side of the body of L1 to the tip of the transverse process of L2. I should have specified the levels of L1 and 2, and finally the lateral arcuate ligament from L1 to the 12th rib. Insertion, aponeurotic central tendon, like we mentioned earlier. What is the action of the diaphragm? The diaphragm is one of the respiratory muscle which can help with the inspiration and expiration by creation of a negative pressure inside the thorax. What is the motor nerve supply of the diaphragm? It takes from the phrenic nerve C345 origin. Okay. What is the sensory nerve supply of the diaphragm? That's quite an important question. We have the basically the central part and the peripheral part of the diaphragm. The central part is supplied mainly by the phrenic nerve, and this is C345, and the peripheral part will be supplied by the thoracic or the intercostal thoracic nerves. Okay, great. What is the clinical relevance of this sensory supply of the diaphragm? With any irritation of the diaphragm from any sort of inflammation in the abdomen, if the central part is irritated, there'll be radiation of the pain to the right shoulder. And this is why in acute cholecystitis, the pain will be radiated to the right shoulder. On the other side, if the peripheral part is irritated, that will lead to more local signs or more local irritation or pain. Brilliant. So irritation of the peripheral part more locally, and also the central part, like we said, will go to the right shoulder or the left shoulder. It depends on the site of the irritation. But as an example, the gallbladder is on the right shoulder. What is the blood supply of the diaphragm? We have many branches that can supply the diaphragm, and this is the superior and inferior phrenic arteries, and both of them arise from the aorta. We have from the internal mammary artery, the musculophrenic branch can give some blood supply to the diaphragm as well. In addition to that, we can have some blood supply from the intercostal vessels, okay? And obviously that would be venous and arterial as well. So I mentioned superior and inferior phrenic arteries, the musculophrenic branch of internal mammary or internal thoracic artery, and a small contribution from the intercostal arteries to the peripheral part of the diaphragm. The next, we're going to move on to the abdominal blood vessels. And the first question is asking about the vasculature of clinical significance in the anterior abdominal wall. And I think here we have 3 important vessels and veins, and starting by the superficial epigastric vessels, and it is superficial to the rectus abdominis muscle or the rectus sheath, and it's a continuation of the femoral vessels, and it anastomoses with the veins around the umbilicus or the umbilical veins, and this is one of the sites for portosystemic anastomosis, and it is responsible for caput medusae in case of portal hypertension. On the other side, we have two deeper veins, which is deep to the rectus abdominis muscle, rectus sheath, and this is the superior epigastric artery as a continuation of internal mammary artery or internal thoracic artery, and the inferior epigastric artery as a continuation of or as a branch from the external iliac artery. They both anastomose together and represent a clinical significance. And I'm going to mention the clinical significance on a diagram now. So superficial epigastric vessels or veins, tributary of the femoral vein, and these veins often anastomose with patent para-umbilical veins and lead to caput medusae in case of portal hypertension. On the other side, major vasculature that includes the superior and inferior epigastric artery and veins. And these vessels, superior epigastric artery is a continuation of the internal thoracic artery, and the inferior epigastric artery is a continuation of external iliac artery. And as you can see on this diagram, you have one, this is the inferior epigastric artery, as you can see, and on the other side, this is the superior epigastric artery, and the inferior is a branch from the external iliac, the superior is a branch from is a continuation of the internal mammary artery, and that is the rectus sheath, as you can see, and it's flipped just to see these arteries just below the rectus sheath. Well, the clinical significance, so when you're doing the laparoscopic appendectomy, for example, you're going to insert the 3 ports. One port will be right there, the other port will be in the midline, so you have one there and one there, and the third port will be basically in the left iliac fossa. And if you go a little bit closer to the midline, you might injure the inferior epigastric artery and vein. So we need to avoid that by going a little bit lateral in that area instead of very medial to that. Okay, so it's around 5 centimeter from the iliac crest, the anterior superior iliac spine. That will be the site for that port. But if you go very, very medial, you might injure the inferior epigastric artery and vein. The other significance is it represented the lateral boundary of Hasselbalch triangle, and this is in case of in the case of the direct inguinal hernia. Okay. Moving on to the blood supply of the gut, we need to identify number 2 very quickly. I'm going to identify the important structure. 2 is the celiac trunk. We have 11. This is the left gastric artery, and you have 25 in the splenic artery, and 3 is the common hepatic artery, and 10 is the hepatic artery proper, 21 is a dilated lymph node, and 1 is the caudate lobe of the liver. And yeah, I think these are the important structures. Maybe you have 12 and 14. 12 is the anterior branch of the left gastric artery, and 14 is the posterior branch of the left gastric artery as well. Super. I mean, the main thing that you need to know here is the celiac trunk, but feel free to stop the video and compare the answers with the others, all right? So here again, so this is just as a confirmation to the celiac trunk. So you have the celiac trunk here, will give the left gastric artery, as you see, which will give at the end anterior, posterior branch, and also the esophageal branches as well. You have the splenic artery, which takes a tortuous course just behind the stomach and on the upper border of the pancreas, which can give some pancreatic branches, and will end in the spleen by giving multiple terminal branches and also giving the short gastric vessels as well. And it also passes through the lienorenal ligament as well. Yeah, and then the common hepatic artery, which will give the hepatic artery proper, and the gastroduodenal artery will be going downward. I think this is the gastroduodenal artery, and the gastroduodenal artery will give the superior pancreaticoduodenal artery and supraduodenal artery as well. And the pancreaticoduodenal artery, the superior pancreaticoduodenal artery is anterior and posterior, which can give the right gastroepiploic. It might be confusing. Please revise that, and you will be able to follow if I may speaking quicker. Yes, let's move on. So we have number 30. This is the superior mesenteric vein. So the vein will usually be on the right side. And 29, this is the superior mesenteric artery. Yeah, and as you see here, this is the artery and vein 29 and 30. Identify 1 and 10. All right, let's move on. Let me just get that. So 1 will be the abdominal aorta, and 10 will be the inferior vena cava. So I will just focus on the important structures in here. Obviously, that is the duodenum, which is flipped sort of backward, okay? Identify number 5 on this one. So 5 will be the inferior mesenteric artery. Obviously, if we need to identify more, 17, which is this one, that's the superior rectal artery, these sigmoidal branches, and number 6 will be the left colic artery. All right, so inferior mesenteric artery, we said 6 is left colic, and then sigmoidal branches, superior rectal artery as well. Well, I'm just gonna focus on the important structures, but here you do have, this is the superior mesenteric artery, this is jejunal branches, and then you have the superior mesenteric vein on the other side. And of course, there are some iliac branches down there as well, as you can see, from the superior mesenteric artery, and this discusses basically the branches of the superior mesenteric artery, including you have the jejunal and iliac branches, and right colic and middle colic and ileocolic branch as well. And the vein, it confirmed that the vein is on the right side and then the artery on the left side. If you confuse that one that we saw early, so this is the vein and this is an artery 29. Okay. On this one as well, that's an even clearer image. So you can see that this is the marginal artery, as you see on this side, and you have the middle colic and then the right colic as well, and finally ended by ileocolic, and you have marginal artery, and this is finally appendicular artery, which is a branch from the ileocolic artery. This is the inferior mesenteric artery, and as you can see, the superior mesenteric will be going sort of downward and on the right. The inferior mesenteric will be going downward and on the left side. Okay. Inferior mesenteric artery have left colic and sigmoidal branches, and superior rectal, which we confirmed today. Abdominal aorta, and we're going to move on to the surface marking of abdominal aorta. So the surface marking of abdominal aorta from the level of T12 to the level of L4 by dividing into two terminal branches. T12 is 4 centimeters above the transpyloric plane, and the L4 will be the intercrestal line between the two iliac crests, the higher point of the hip bone, basically, in the midline. All right. So to identify where is the transpyloric plane, so draw a line from the suprasternal nose to the symphysis pubis, and the midpoint will be the transpyloric plane. Right. So this is the way I'm going to answer in the exam. Like I said, T12 to L4, T12 4 centimeters above the transpyloric plane, and L4 is the transcrestal or intercrestal line between the iliac crest bilaterally. The branches of the aorta, the way I like to answer, I know people like to answer this by the levels. You have like one at T12 and L1 and L2, but I prefer to answer it from anterior branches and lateral branches and posterior branches and terminal branches. So I'm going to start by the anterior branches. This is the celiac trunk at the level of lower border of T12, superior mesenteric artery, upper border of L1, and the inferior mesenteric artery, and that will be the L3 at the level of L3. And then we have the lumbar branches, 4 lumbar branches coming bilaterally. You have the inferior phrenic and suprarenal, and also the renal arteries on both sides, middle suprarenal and then renal arteries on both sides. We have some gonadal vessels or gonadal arteries arising from the aorta, gonadal, whether it's ovarian or testicular artery in the male and female patients, and 2 terminal branches, and that will be the common iliac arteries. Okay, and then the levels, I will just mention the levels briefly. So we have celiac trunk, T12, L1, SMA, L2, upper border of L2, lower border of L1, and then IMA, which will be L3, lateral side, inferior phrenic, middle suprarenal, and renal arteries. Posterior will be lumbar branches, gonadal, and median sacral artery. I did not mention median sacral artery. And finally, terminal, which is the 2 common iliac arteries. What is the anterior relation of the abdominal aorta? I remember it's 4 blood vessels and 2 organs, and there is the mesentery, or the root of the mesentery. Obviously, in an exam setting, I will not answer like this. Keep the scheme in your mind, but just to start answering the question. So, okay, let's assume I'm starting to answer now. So anterior to the abdominal aorta, there will be the splenic artery, superior mesenteric artery, and celiac trunk, and left renal vein. Okay, and also the duodenum and the pancreas. Specifically, we're talking about the third part of the duodenum and also the pancreas as well. And the root of mesentery, that is all the anterior relations of the abdominal aorta. Okay, so 4 vessels, 2 organs, and 1 mesentery, root of mesentery, vessel, celiac trunk, SMA, renal vein, and splenic vein as well, or splenic artery. Mainly splenic vein, sorry, it's not artery. Organs, pancreas, and second part of the duodenum, as you can see. All right, let's identify some structures in here. So this is, as you can see, an angiogram. A is the abdominal aorta, and then we have B on this side. They said the right common iliac artery. C is left common iliac artery. D is left renal artery. E is right renal artery. And F is the left middle suprarenal artery. Or actually, F is the splenic artery because it does have a tortuous course. And G is the common hepatic artery. And J is the left hepatic artery. and K is the right hepatic artery, and I is the gastroduodenal artery. So I'm sorry about F, but I'm pretty sure that now this is splenic artery, and we can find out the answer. So look in here, so F will be splenic artery. Yeah, great. Identify the following CT angiogram again. So let's see. So in this CT angiogram, you can see the abdominal aorta here with some sort of blood around it. So it looks like an infrarenal, because we can see the kidney bilaterally, abdominal aortic aneurysm. All right, so that's the answer, infrarenal AAA. Define an aneurysm. It's an abnormal dilatation of an artery due to weakness of the three layers of the wall, and the dilatation needs to be 1.5 the size of the normal artery, okay? Or maybe 50% more than the normal size, okay? More than 50% or 1.5 times the normal diameter. The pathogenesis of abdominal aortic aneurysm, it can happen to the loss of intima and tunica media, leads to weakness in the three walls, and the loss of the elastic fibers in the wall can happen due to trauma or median cystic necrosis. And the causes of an aneurysm could be the most common one is atherosclerosis. That's 90% of the patients. Atherosclerosis and hypertension and other factors, but mainly atherosclerosis. We can get connective tissue disease, Marfan syndrome, and infection such as mycotic aneurysm, which can be fungal or bacterial or anything, and also the congenital abnormality or congenital weakness of the wall, atherosclerosis, infection, and also congenital weakness and connective tissue disease, such as Marfan syndrome. Dissecting aneurysm, it happens to do injury into the intima, which lead to tracking of the blood on the wall of the blood vessel and lead to accumulation of the hematoma in the wall, which causing a pseudo or a false dilatation in the wall. All right. So this is a dissecting aneurysm. Separation of all the layers due to injury of the intima will lead to propagation of the hematoma inside the wall. Identify 39 and 40 on this one. So let's have a look. We can even identify more. So I think 40, if you look at 40 coming here all the way down, well, let's assume answering the exam, 40 is the ureter, and I'm not going to say right or left because this is right and this is left, and they both have the same marking, which is 40. Well, 39, it's even clear on this side. 39, it's something that is blue. I believe that this is the right gonadal vein. Right gonadal vein. 23, for example, is the inferior vena cava. 1 is the abdominal aorta. 3 and 3 on both sides, these are the common iliac arteries. 7 is the left external iliac, and this 7 is the right external iliac. 8 is the, looks like this is external iliac veins, and 25 is internal iliac. Maybe 16 is hypogastric plexus. Maybe, yeah, I think these are the important structures I could see on this one. But generally, 39 gonadal vein and 40 is ureter. Inferior vena cava, what are the tributaries of inferior vena cava? We have the two common iliac arteries, and also we have the lumbar veins, we have the renal veins bilaterally, and we have the suprarenal vein and also the inferior phrenic vein as well. These are the tributaries. We can also have the portal vein or the hepatic vein as well as one of the tributaries. There anything else at the tributaries? Let me check. So common iliac vein, two renal vein, suprarenal vein, and also I should have mentioned right suprarenal vein, lumbar veins, gonadal vessels, and hepatic vein. I think I did not mention gonadal, but yes. All right. Renal vein, the question is asking about the anterior relation of renal vein. And the answer is, so on the left side, we have superior mesenteric artery and splenic artery, and also the pancreas. And on the right side, we have the duodenum as anterior relation to the renal vein. Let me check. I'm not sure really. So second part of the duodenum, that's right. And superior mesenteric artery, I said splenic artery, but it's actually splenic vein. And the body of the pancreas, I should have specified that it's the body of the pancreas as well. The next part will be abdominal organs, starting by the esophagus. First question is asking about the beginning and the end of the esophagus. The esophagus begins at the lower border of cricoid cartilage at the level of C6 and ends at T11 by continuation into the cardia of the stomach. blood supply divided into venous and arterial blood supply. Starting by the arterial blood supply, the cervical part will be supplied by the inferior thyroid artery, and this is from external carotid artery. And then the thoracic part supplied by the esophageal branches from the thoracic aorta. And ending by the abdominal part will be supplied by the gastric branches. To be more specific, at the left gastric artery from the celiac trunk. The venous drainage for the cervical part will be the inferior thyroid vein into the brachiocephalic vein. And the thoracic part will be into the azygos vein. And the abdominal part will be through the gastric veins, and that will go through the portal vein, and it's one of the sites of portosystemic anastomosis. So arterial supply, inferior thyroid artery, and aortic branches, and also the left gastric artery, like I mentioned, and then venous drainage, inferior thyroid to brachiocephalic, then azygos vein, and left gastric vein to portal vein. The lymphatic drainage in the cervical part, we have the deep cervical lymph nodes, thoracic part in the mediastinal lymph nodes, abdominal part into the gastric lymph nodes. Let's see that. Yes, and the muscularis externa of the esophagus. In the upper third, we have a striated muscle. The middle third, it's both striated and smooth muscles, and the lower third, it will be only smooth muscles. Yes, as you can see here, what are the cell types of esophageal lining of the esophagus? It's a non-keratinized stratified squamous epithelium. Yeah, and that will take us to define Barrett's esophagus. It's the presence, or basically it's a metaplasia of non-keratinized stratified squamous epithelium into a columnar epithelium, which basically is the lining of the stomach, in addition to presence of columnar metaplasia as well. Okay, so this is the definition of Barrett's esophagus. As you can see, obviously, presence of columnar metaplasia will lead to increased risk of adenocarcinoma of the lower third of the esophagus. The achalasia, it's one of the lower esophageal sphincter motility disorder, characterized by absence of myenteric plexus and the increased lower esophageal sphincter tone and loss of relaxation of the lower esophageal sphincter. So that's the definition of achalasia. All right. So motility disorder of the smooth muscle layer of the esophagus at the lower external sphincter. We have loss of sphincter relaxation, increased sphincteric tone, and lack of peristalsis as well. Microscopy, absence of myenteric plexus, and also loss of relaxation, hypertrophied muscles at the lower end. The sites of esophageal constriction, that will be the cricoid cartilage, the left atrium, and also the main bronchus, the left main bronchus, and the diaphragm as well. There is one more which I don't remember, so let's check. So cricoid cartilage, the arch of the aorta, I missed this one, left atrium, left main bronchus, and diaphragm. What is the complication of esophageal perforation? It can lead to mediastinitis. The last rib to feel in the mid-axillary line will be the 11th rib. Stomach, starting by stomach with, again, few questions. The labeled structures in here. This is the fundus of the stomach, the body of the stomach, the pyloric antrum, the pyloric canal. 23 is the first part of the duodenum. Okay, and again, you can check all these structures: body of the stomach, fundus of the stomach, pyloric antrum, pyloric canal, first part of the duodenum. Parts of the stomach, I think they're mentioned in here: body, fundus, and also the pyloric or pyloric canal or antrum. Moving forward, as you can see here, this is the lesser curvature of the stomach. That's the greater curvature of the stomach. That's the fundus, and then this is the body, and ending by the pyloric canal or pyloric antrum, and then this is the first part of the duodenum. You can see the rouge from the inside of the stomach in this opened section. Blood supply of the stomach. So we're going to have the celiac trunk will give the left gastric branch, and then the hepatic artery will give the right gastric branch, and this is on the lesser curvature. On the greater curvature, we have the right gastroepiploic from the gastroduodenal artery, and left gastroepiploic, and that will come from the splenic artery. And finally, we're going to have the short gastric arteries on the fundus, and this is from the splenic artery as well. The venous drainage will follow the arterial blood supply. It's very similar to it. So left gastric, right gastric, left gastroepiploic, right gastroepiploic, and then short gastric. Venous drainage follow the arterial drainage to portal vein, splenic vein, superior mesenteric vein. This diagram quite explains it quite well. And again, that's a dissection that explains it in the same way, which I think we've covered this one before. Duodenum. What is the peritoneal covering of the duodenum? The whole duodenum is a retroperitoneal organ, apart from the first part, which is enclosed intraperitoneal. And I think, yeah, blood supply of the duodenum, it's mainly supplied by the gastroduodenal artery by giving the supraduodenal and the superior pancreaticoduodenal, which is divided into anterior and posterior branches. And also it has blood supply from the inferior pancreaticoduodenal artery, and this is a branch from the superior mesenteric artery as well. However, we need to mention the venous drainage as well, which will follow the arterial supply, and this will obviously go into the portal venous system. So arterial, like I said, superior, inferior, and supraduodenal, and then venous will follow to the superior mesenteric vein and portal vein. The relations of different parts of the duodenum. I think this is a long question, so I'm going to cover the major duodenal papilla first. So it's a conical in shape papilla present in the posteromedial part of the second part of the duodenum, and this is 10 centimeter from the pyloric antrum, and also it represents the major drainage for the major duodenal papilla. So let's see the answer quickly. As you can see, conical projection, posteromedial wall, 10 centimeter from the pylorus into the second part of the duodenum, and also its opening for main pancreatic duct. This diagram is quite good. As you can see here, that white structure, this is the main pancreatic duct or the major pancreatic duct, and this is the major duodenal papilla. What is the relation, or what are the relations of the different parts of the duodenum? So we're going to classify this to the 4 parts: first part, second part, third part, and fourth part. The first part relation, anteriorly, it's related to the quadrate lobe of the liver, or maybe you can say the right lobe of the liver, and the body of the gallbladder. And posteriorly will be related to the common bile duct, the portal vein, and the gastroduodenal artery. Superiorly will be related to the epiploic foramen, inferiorly to the head of the pancreas. And then the second part, anteriorly related to the gallbladder and the right lobe of the liver, transverse colon, transverse mesocolon. Posteriorly, the right renal vein, the kidney, and the part of the psoas muscle, and maybe part of the ureter as well. And that would be posteriorly. Medial would be the head of the pancreas, and then lateral would be quite similar structure. You can see the ascending colon and the hepatic flexure of the colon as well. So let's see the first part, anterior, we said quadrate lobe, gallbladder, portal vein, gastroduodenal artery, CBD, epiploic foramen in the superior part. Second part related to the anterior gallbladder, right lobe of the liver, transverse colon, transverse mesocolon. I did not mention coils of intestine. And then posterior, right kidney, right renal vein, right edge of the inferior vena cava. I didn't mention this. It's quite a long question, to be honest. And then right psoas major muscle, head of the pancreas, ascending colon, colic fracture, and right lobe of the liver in the lateral part. Okay, let me think. The third part of the anterior relation will be superior mesenteric artery and vein, and again we'll have the transverse colon, transverse mesocolon, and coils of jejunum and ileum as well anteriorly. And then posteriorly you will have the kidney, the gonadal vessels, and also the ureter, and you can have again coils of jejunum and ileum, and finally the abdominal aorta as well will be there. If you remember the anterior relation of abdominal aorta, we mentioned the duodenum as one of the 2 organs related to it. And then superiorly the head of the pancreas and body, and inferiorly will be the coils again of ileum and jejunum. So let's see quickly. Superior mesenteric artery vein, I've got this correctly. Psoas major ureter, I've got this correctly. And answer process and pancreas, great. Coils of jejunum inferiorly as well. The fourth part will be very similar to the third part. So you can have anterior as the root of the mesentery, transverse colon, the coils of jejunum and ileum. Posteriorly, you can still have the right psoas major muscle, the ureter, the gonadal vessels. I think inferior vena cava will not be related to it, but yeah, I think these are the major structure posteriorly. And again, superior and inferior, very similar to the third part as well. And you can check the answer in here very